The importance of an efficient and coordinated discharge process has never been greater. Studies have found that improvements in hospital discharge planning can reduce readmissions and prevent complications, dramatically improving the outcome for patients as they move to the next level of care. Preventing readmissions has the potential to profoundly improve both the quality of life for patients and the financial well-being of healthcare systems. Medical Service Company's Hospital Discharge Acceleration Program combines best-in-class technology, patient management software, and perhaps most importantly, customer service to provide the patient the equipment and services they need to discharge from the hospital as safely and quickly as possible, so they can return to where they are most comfortable, their homes. At the end of the day, it is our people that make the difference. Our respiratory therapists, hospital liaisons, and all the frontline staff that care so much for the health, safety, and outcomes of our patient population. To learn more about this program and other services we provide, please visit our website at medicalservicecode.com for more information.
I hope you're enjoying this day of healthcare education. This brings us to our final session for today in the respiratory track presented by Dr. Keith Robinson. He will be speaking about the COVID-19 pandemic in the clinical environment and the implications for long-term and short-term oxygen therapy. Dr. Robinson currently serves as a medical director at Syneos Health, an end-to-end fully integrated biopharmaceutical solutions company. Previously, Dr. Robinson served as an associate medical director at IQVIA and a medical director for the Fusion Health and Wellness Pulmonary Rehabilitation Clinic in Fort Lauderdale, Florida. Additionally, Dr. Robinson is a board-certified pulmonologist and critical care medical intensivist with the North Broward Hospital District. As you listen to the lecture, you can submit your questions for Dr. Robinson under the Engage tab. As a reminder, to receive credit for attending, please complete and submit the evaluation at the conclusion of this session.
I'm Keith Robinson. I'm a pulmonologist and a critical care intensivist located in South Florida. I've been asked to speak with everyone tonight about COVID-19, and I think the specifics of what we'll be going through today will be the use of oxygen in patients unfortunately infected with COVID-19 during this pandemic. So the title is Implications for Long-Term and Short-Term Oxygen Therapy. So my objectives are fairly straightforward. I think I'll go through the early presentation. I'll go through the phases. I think when we talk about phases of infection for COVID-19, we may actually have a fifth phase now, but I'll go through the four phases as we know them prospectively from March to now. And I think the current environment in regards to how we decide who's at the end of infection will be an important part in regards to the discharge planning that many of you will have to do with patients infected with COVID-19. So we'll go through that patient discharge planning, key contacts for planning, maybe describe what recovery looks like. I think many are probably familiar with the things that we're seeing now in some patients who have not fully recovered from COVID called long hauler. So we'll go through that in regards to how it's managed. And then we'll go really quickly through how oxygen delivery and pulse or continuous delivery can affect the recovery stage of patients with COVID-19. And then finally, I thought I'd try and put together some impacts onto chronic illnesses like COPD, heart failure, cancer, pulmonary fibrosis, pulmonary hypertension, simply because these are generally patient populations that may already have oxygen therapy, in which case you need to titrate their care going forward after infection. So with that in mind, I think the four phases as we've recognized COVID-19 starts with being exposed. And I think the sad part about the infection is that we're learning that herd immunity may be really hard to achieve. We recognize that after infection, some patients don't develop a good enough antibody response or a poor antibody response to lead towards lifelong immunity towards the virus. And I think the other thing we're recognizing, unfortunately, is that there's what I call a bolus of virus that you have to be exposed to in order for your bodies, our bodies specifically, to make a good immune response. And I think that's maybe why in at least the last second wave and now the uptick in the third wave that we're now experiencing, the number of patients becoming critically ill and requiring ventilators may be not as high as, say, March when I first started taking care of patients with COVID. So, I think the things that we've learned about this virus since March to roughly June is that some patients get, unfortunately, very sick. And the degree to which some patients get sick really has to do with how much virus they're exposed to. And so what we recognize, since we've all been socially distanced, since we've all been wearing face masks, is that from time of first infection back in March to our second wave back in June, July, we recognized that the amount of virus in the environment decreased. And therefore, the severity of illness that we were seeing from March to May was not quite the same as what we were seeing in June and July of this past year. So I think the thing that I always remind my residents are that when we talk about the virus, it's not just that you've been exposed to the virus, but how much of the viral particles you're exposed to that leads towards severe illness, and in some patients, critical illness. And so I think as we start working towards the winter, and unfortunately some families have to live amongst each other because of shared housing, we're likely to see that the viral loads are going to go back up. And unfortunately, we're likely to see the severity of illness and critical illness to go back up as well. So for me, the idea that we can try and minimize how much virus we get exposed to also changes the trajectory of how ill patients will become should they become exposed to the virus. You know, I like this slide because I think much has been spoken about in regards to how we develop immunity. And if you have been reading the literature of late, you know that we have really kind of two types of immune responses that we're asking our bodies to do. Well, the first being the innate immune or the natural immune system, which is the very first part of our immune system that would counteract the virus and in many ways hopefully deal with the virus up front so that we don't get gravely ill. Then the second would be what this slide demonstrates, which is our adaptive immunity. So what I've demonstrated here on the slide is that when we have patients that present, there may be actually a week or so before patients have onset of their symptoms that require them to go to hospital. And so when we talk about what type of testing you need, you certainly want to have a test that's going to be rapid, and you certainly want to have a test that's going to be highly specific to the time frame for which you were exposed. And I think I've had many of my prior patients ask whether they should have antibodies tested. But as you can see on the slide, antibodies can be a lagging indicator of whether you've been exposed or infected, in fact, almost 2 weeks later. And so I think the idea that you may have symptom onset maybe a week or so after your exposure means that there's a large amount of people that are asymptomatic or what we call pre-symptomatic that are still walking amongst us in the community, in which case, again, socially distancing as well as wearing a face mask will be so important in that first couple of weeks of exposure, simply because our adaptive immune system, the immune system that helps us to have lifelong immunity to any virus, takes so much longer to actually kick in and start to give us some degree of protection. So I think if you have the opportunity to have a rapid test done, certainly right after the time you've been exposed, you're likely to hopefully to be able to quarantine and stay away from folks. So teased out, the fact that there are probably now 5 phases of this infection. And what the slide demonstrates are really the 3 that we recognized after the first pandemic wave in the spring of this year, which was that there was the viral phase or that stage 1 early infection. Again, some patients can go a full week without knowing they've been exposed and certainly don't come to hospital or to the emergency department for evaluation simply because they haven't had symptoms that are high enough or great enough. So I think the idea that as clinicians, we really want to have folks remember that if they are not socially distanced or they do have exposures where they go to family dinners or to weddings, that they might have that opportunity to unfortunately have early stage infection. And what we're recognizing in regards to therapies for patients are that if you've got early stage infection and your body mounts the wrong immune response up front, then you're likely to fall into, unfortunately, the stage 2 or the second stage of infection. And that's really where we see most patients come into the facilities for testing and, more importantly, hospitalization due to severity of illness. So what I've got at the bottom here are some clinical symptoms that many patients may present with. As I said, a lot of folks have had opportunity to be exposed and maybe not put together that they don't feel well with the fact that exposure might be COVID-19. We've recognized dry cough. We've recognized fever, certainly headache, any change in bowel habits associated with exposure, all the loss of taste, the loss of smell, are all the symptoms that we now recognize with this virus. So if you have any of those symptoms occur, absolutely start to quarantine and then again, try and get a rapid test done as soon as you can. The whole idea is that if we can mitigate how many patients fall into stage 2, then we can also hopefully decrease the number of people that get gravely ill and end up in the hospital. And unfortunately with me in the intensive care unit. So stage 2 becomes a really critical point in care in regards to who's going to do well and who's going to do poorly with this virus. And what we see is that, and I think many have heard of what's called the silent hypoxia, where some patients present to the hospital with oxygen saturations in the 80s, but look very comfortable. And so it's a reminder that our bodies don't necessarily tip us into breathing harder based on how low our oxygen saturations are. So carbon dioxide drives how we breathe. And so you can get quite to a level of low oxygen before you actually come to a facility. And I think that's the danger in regards to this virus, is that many patients may sit at home, not feel quite so hot, and not maybe recognize that their oxygenation may also not be where it needs to keep all the vital organ systems safe. And I think that's what we learned between stage 2A and stage 2B, is that if you waited too long to come to the hospital and you fell into stage 2B, that you were less likely trying to fight off the virus, but very much trying to keep your life and in regards to having the right inflammatory response to the secondary sequelae of the virus. And so I think some of the therapies that have come to market, some of the things that we've tried to mitigate this virus haven't worked so well, simply because this virus isn't easy to eradicate. More importantly, many patients aren't familiar with when they've been exposed. So we call it a Goldilocks phenomenon, which is you have to give the right dose and the right medication at the right time. And so in many regards, the reasons that, say, convalescent plasma hasn't worked for many, hydroxychloroquine or chloroquine haven't worked, more importantly, why remdesivir may not necessarily save your life, but it'll certainly get you home sooner, is that you have to give it when the virus is still at a point where it's shedding. Otherwise, you're really dealing with the host response, or your body's natural ability to either keep yourself safe or, unfortunately for some, fail. And so the clinical signs that we look for in that regard are generally going to be the imaging that tells us that you've had viral illness or viral pneumonia. More importantly, we're likely to have done a blood gas, arterial blood gas, looking at your oxygenation. And so we can diagnose in some patients having what looks like ARDS based on what's called the PF ratio. So anything less than 300 millimeters of mercury would qualify as having hypoxia due to ARDS. And then more importantly, some patients have what we call cytokine storm. And I think early into the course of this infection in stage 3, we had really the wrong impression of what the cytokine storm was doing. We had every thought that the cytokine storm was leading towards the ARDS that we can see in patients with COVID-19, only to find that the therapies that we would use for ARDS up front in the early stage of ARDS don't work all that well. So again, reminding us that there's probably something else that's happening in these patients, not just the inflammation associated with the infection, more importantly, not just the infection itself, but we're having an inappropriate amount of inflammatory response that doesn't help to keep and protect the patient from falling into the intensive care unit. So I think some of the therapies I've listed here at the bottom, corticosteroids we recognize in ARDS work in severe and critically ill patients, simply because, again, in ARDS, you can have what's called a monoclonal or at least a mononuclear cell response, which is early. So that's going to be more macrophages. Or you can have what's called a neutrophilic response, which would be more of a late stage response. And I think that's where the dexamethasone that's working now in patients is working specifically, is in that second stage of ARDS and not the early phase or early presentation of ARDS. But I think the idea that, again, we've got more therapies that are listed here at the bottom that are currently being studied means that we're actively looking to help the body's inflammatory response to become more appropriate with this virus as it progresses from stage 1 through stage 3 in some patients. Stage 4 is what we're going to discuss coming up. So when we talk about that viral phase, this simple cartoon just demonstrates what we know. The virus likes to bind to ACE receptors within the body. And so you're either going to have an upregulation or a downregulation of those ACE receptors, depending on how your body responds to the virus. Generally, an upregulation will occur, which also leads towards vasoconstriction in the periphery of the blood vessels. But we do also recognize that angiotensin has an activity to recruit or at least increase the amount of white blood cells that get recruited to damaged or injured lung. So we have the vasoconstriction associated with the virus. We have the inflammation of the viral endothelium due to the virus itself, which leads to the secondary cytokine elevation that we've been discussing. Increased vascular permeability, so the leak that goes along with, unfortunately, having ARDS. And then, as I mentioned before, neutrophil recruitment to the lung, which is probably a reperfusion injury, as we now start to look at CT scanning and looking at CAT scans of the lung in patients who've been affected with COVID and recover and go home. So I suspect we are seeing what looks like a reperfusion injury and not just prototypical ARDS as we would see it in patients who had other infectious causes. Now, this is a busy slide. But I really wanted to kind of give the landmark between first phase and second phase of infection, or first stage and second stage, so that you understood exactly how this virus is affecting the normal vasculature of the lung, reminding that the vasculature of the lung, we have dual blood supply, meaning that we have two different ways to get oxygen in and out of the lung. But more importantly, where certain therapies might benefit, where certain therapies might hurt, but also talking about the risk factors that we recognize. So age, being a man, being a tobacco smoker, maybe have some risk factors for arteriosclerosis or hardening of the arteries, which is generally what we see a large degree of macrophages. The pearl there being that macrophages drive this infection. So if we can turn off the macrophage, specifically in the interstitium of the lung, less likely to have some of the downstream effects of this virus causing more endotheliitis and more ARDS-like pattern due to reperfusion injury. But again, thrombosis we see regularly. So if patients are at risk of having clots or have had clots before, we do recognize that they're at greater risk of having more clotting associated with this virus. And then I think when we talk about the second phase, these are really looking at the therapies that are currently under investigation, because I think the idea that there's more than a one-hit phenomenon, it's not just the virus itself, but it's the milieu of cytokines that the body will sit within, again, not causing the ARDS, but causing local damage to the microvasculature of the lung and maybe the microvasculature of some of the important vital organs like the kidney, the liver, the brain we're recognizing. So I think some of the pearls that we're recognizing is that hypoxemia drives this injury to the body, as it does in most critical illness. And so if we can recover and more importantly, stabilize oxygenation in patients up front, we're likely to have less end organ damage and hopefully less long hauler symptoms as patients recover and end up going to either skilled nursing or home. So this simple cartoon just demonstrates again that there's the phase 2, which is broken into A and B. But what it demonstrates is that not only do you have what's called a VQ mismatch, which would be low, but you also have shunt physiology right to left. So shunt physiology being that when you have oxygenation that comes from the right side of the body, it doesn't get oxygenated through the lung and then is dumped right back into the heart to be distributed to the vital organs of the body. So poorly oxygenated blood being redistributed to the body. Again, we do see the diffusion abnormality that would suggest ARDS pattern, and then hypoperfusion. So those little yellow areas where the pruning of the blood vessels are found, those would be microclots that occur within the capillaries. I think with my residents, when we first saw this virus, I had rather probably inappropriately joked that if you were going to erase millions of years of evolution, the things that got us up out of water and walking on this planet, that's essentially what this virus has done with one infection. So if you've got, and these are 4 of the classic causes of hypoxemia. And so if you're going to knock out our ability to be safe, you're going to knock out our ability to do all 4 of these things right up front. And unfortunately, that's exactly what this virus does rather efficiently. The other thing we learned, and I think if you're a respiratory therapist, you've probably been more attuned to this, is that we've been kind of distressed by the fact that some patients seem to do worse on a mechanical ventilator than better. Again, our early impression was that because the PF ratios or the ARDS ratio that we would look for was so low, that what we were really treating was ARDS patients, and only to find that that's not true. So this slide actually, I think, rather elegantly demonstrates the comparisons between a COVID-19 lung, which looks by volume to be about the same as a healthy lung. I hope you can appreciate the purpling, which are dilatations that occur within the lung. So clotting that causes back pressure, more of a pulmonary vascular source of concern. I hope you also can pick out the small little yellow areas within that lung of the COVID-19 patient. So areas that are poorly perfused or hyperperfused, where they should be nice plump red, they're yellow, suggesting hypoperfusion is occurring. And then, when we compare that to other disease states that are similar, so pulmonary hypertension being the bottom left and then ARDS on the bottom right, we can see the volume of the lung has not been affected by COVID-19. Very clearly, the vasculature has been affected, but the volume has not. And so I think that's why in some settings we've been able to get away from trying to use protocols for ARDS in patients' early presentation, mostly because I think we now know that endotheliitis drives this infection up front in stage A, or 2A, that we do recognize pulmonary vascular sources, so pulmonary emboli, and unfortunately clots within the microvasculature or the capillaries of the lung. We do see ARDS, so I don't want to overstate that it's not as significant, but we do see ARDS pattern. Again, I think that's reperfusion. And then I think in some patients, unfortunately, mostly patients over the age of 65, they've had inability to come off a ventilator simply because the reserve of the lung and the reserve of the heart has been affected by this virus, leading to ventilator-dependent respiratory failure. But this is what we look at, and I think this is what I'm fearful for going into November, December of this year, is that we unfortunately had the ability to stabilize a good number of patients. So we go into what's called phase 3. Phase 3 is that prolonged hospitalization. I think many, if you watch the lay press and maybe watch the local news, are unfamiliar with the fact that some patients are on ventilators for 3 weeks. So if you lose 21 days of your life to a virus simply because of the secondary consequences, there almost certainly will be what we now recognize as the fourth stage, which is, a lot of patients are disabled due to this virus. And so I think the idea that in phase 3, you're either going to get better or you're not. And I think that's just the sad part about this virus now, is that we really have gotten good at predicting who's likely to end up in phase 3. But we really haven't done a very good job of deciding who's likely not to make it through phase 3 and into phase 4, which is hopefully discharged from the facility to manage their disability associated with becoming critically ill. So I just use this quickly just as a reminder that we know that having a lot of comorbid disease, so diabetes, hypertension, previous heart disease, those are all risk factors for having an outcome that's not favorable associated with this virus. So as a reminder, I think what we learned about not just being over the age of 65, not just being a man, but, the risk factors generally for folks not to do well. And the reason diabetes, hypertension, heart disease, all those things go together is atherosclerosis. Because again, this is a macrophage-driven phenomenon because macrophages are associated with chronic inflammation. More importantly, the macrophage sits in between the innate immune system and the adaptive immune system in regards to how our body's going to respond to this virus. And so I think the idea that, what we're talking about for folks at risk of having bad outcomes is really a Western diet. How healthy were you in regards to keeping your cardiovascular risk factors low versus those who, unfortunately, there are some folks who are fairly healthy. Again, going to the point that if you get a large amount of virus, sometimes not having any risk factors, just the virus itself can unfortunately cause you to have a loss of life. And I think that goes, again, what we recognize in the second slide here, the second graph, which is that there are a lot of healthy males that unfortunately just, for whatever reason, aren't doing as well as our ladies out in the community. So as I've teased out, we, at least in the early stages, March through May, were really not sure how many folks were going to end up going home. But I was always curious why there seemed to be a large number of positive cases, but we really couldn't tell how many people actually have recovered to go home. And I think that's mostly because how do we define recovery? So I think when we talk about the limited information that we had coming from New York City specifically, about 45% of their patients recovered to be able to go home. Which matches a little bit about what the United Kingdom or England had told us about their folks being able to go home, roughly 49%. So that meant that at least another 50% of folks roughly were still sitting in a hospital bed somewhere. And so the CDC considers patients safe for discharge if they have no fever for 3 days. And more importantly, all the other symptoms have abated to the point where patients are safe and comfortable. At our facility, we do 2 negative COVID tests done 24 hours apart, and determining whether patients are no longer an infectious risk in order to send them home into the community. But I think this really shines a light on, really how do we do what we can and not just keep patients from getting infected, but how do we treat the patients who become infected and then we'll have a protracted recovery. And I think that's a little bit of what we're going to go through in the next couple slides. So where are all the patients? This slide actually is a little outdated. As you know, we've got roughly 9 million folks now that have been tested positive for coronavirus. And we now upwards of 230,000 people have lost their life through the month of October. But that leaves, almost 5 million folks out there that are various stages of recovery. Are they back to work? Are they being productive? These are sort of the things we need to have answered because I think with this next wave, which is expected to be even larger than July, on the back end coming towards spring, how many folks are going to be able to get back to work? We want a productive society. So I think we really need to tackle how we manage to discharge patients and how quickly we get patients into, say, pulmonary rehabilitation, some form of rehabilitation so that, again, we can abate the effect of the disability that we see. And so I am actually taking care of some patients in a post-COVID recovery unit. We've set up some in our local skilled nursing facility simply because they can't go home. But we find that many of these patients have been intubated for quite some time. They're profoundly debilitated because they'd been bedbound for so long. Many have had to use really high amounts of sedation just to keep them safe on the mechanical ventilators or on BiPAP or high-flow nasal cannulas. But they're going to suffer through many months. I've had now folks have been with me at skilled nursing post-discharge with COVID for 4 weeks. And it's sad to tell folks that they're not quite ready to go home when they feel okay. But very, very, very debilitated to the point where, again, they're not safe to take care of themselves at home. So I think the idea in recovery is we really have to start talking about educating our communities about what recovery looks like, that it's not going to be a quick hospitalization for some. It's going to be a protracted hospitalization, and unfortunately likely require a short stay at a acute rehab or skilled nursing facility. So let's talk about discharge, because I think, early on, we didn't know how we were going to manage patients when they were ready to leave the hospital. More importantly, we don't really know how to prescribe oxygen for patients when they leave. But I put this on this slide on the deck simply because I wanted to remind that we were going in the wrong direction. We're well above 60,000 cases now. So, the fearful thing that I have is that we still haven't done a very good job of deciding how we're going to send folks home. Because once you're in the hospital, depending on how many days, you're really going to want your social workers, your case managers to have a plan of care. How do we get you home safely and make room? I hate to say it, make room for more people. But that's where we're headed in this pandemic third wave, is that there are going to be a lot of people hospitalized and a lot of people needing to go home. And I think this, the recovery rates, as we were discussing across the country, just everybody's increasing. And so what this demonstrates, again, is where those cases are increasing the greatest through our first two waves. And then, again, showing the uptick in our third wave. That's unfortunately likely to be a lot higher than 70,000 cases. So I don't know. This is a frustrating thing to see because, again, we haven't really put together a really good national plan for how we're going to get patients home, which means that we're still, I would say, at stage one, not in regards to the infection, but really in the part of planning. So everybody paying attention today, hopefully, has started to think about what discharge planning looks like for COVID patients. And, I've mentioned the silent hypoxia that patients present to the facilities with. And, I think because this is a novel virus, there really wasn't any guidance that I could find in regards to how do we send folks home? How do you prescribe oxygen? I think many are familiar with the CMS or the Medicare standard of 88% saturation or less, especially with ambulation or some evidence of heart failure. So I think, again, in this time frame of having a novel virus, fortunately, most of the agencies have allowed for the discharge plan to include oxygen therapy if you find it necessary. But I've tried to look and see what the standards are, and across 26 countries, as you can see, everybody uses a different cutoff for who goes home with oxygen. So I highlighted the United States. So 92% or less becomes the cutoff for folks who should go home with oxygen therapy. Again, my respiratory therapists are probably familiar with this, which is that we all generally will desaturate or drop our oxygen levels at nighttime while we're sleeping. So I almost certainly want you to ensure that you've assessed your patients, not just ambulating or awake and sitting in a bed, but also reassess them at night. Because I think the idea that many of us desaturate at night means that there are opportunities for folks to have really horrible outcomes, because the most dangerous part of any day for any patient, any person on this planet is nighttime and not daytime. So, I think target oxygen saturations becomes a double-edged sword. It's a catch-22. So what we recognize about hypoxia specifically is that it actually upregulates ACE receptors. And as you know, COVID-19 likes to bind to ACE receptors in order to infect cells. So hypoxia generally will lead towards an influx and uptick in the amount of ACE receptors that are placed onto endothelium, so that, again, it can be vasoactive and doing what it can to redistribute blood flow that's oxygenated to appropriate parts of the lung. But COVID likes that. So again, as I had joked with my residents earlier, and I wish I hadn't, if you were going to devise a virus that was going to work efficiently, you were going to use the machinery that we have naturally to keep us safe against us. And that's exactly what this virus does. But the other thing we recognize is that having low oxygen does cause what's called hypoxic vasoconstriction. So again, the idea is that we want to redistribute blood flow to well-ventilated parts of the lung. And so again, it is a double-edged sword, but I think the idea is you want to target that oxygen level appropriately. And so current targets are generally, and this comes from the National Institute of Health, of targeting saturations of 92 to 96% at all times, nothing above 96%. We don't need A+ students out there with oxygen saturations at 100%. But just keep them safe and well off the steep end of the oxygen dissociation curve. So again, these folks are able to go home safely, and more importantly, you can educate them that that's where they need to sit whenever they're assessing if they do have pulse oximeters at home. So again, that they're able to again keep themselves safe and hopefully not bouncing back into the hospitals unnecessarily. So hot on this slide, in case you're curious, is home oxygen therapy. I use that because again, we don't have a really good definition for what hypoxia looks like in COVID-19 discharge. And I think that's just the new term that's coming out across the international literature in regards to how to get patients out of the hospital and home, is using home oxygen therapy early. But I think the idea is that timing is of the essence at this moment. simply because, again, the number of cases are going up dramatically, which means the number of hospitalizations will start to lag and fall behind. So there weren't very many models to at least follow in regards to, what do COVID patients look like when we're doing ambulatory saturations? And so I tried to find some papers, and I found one that compared patients with COVID-19 to patients with IPF, or idiopathic pulmonary fibrosis. And what we see here is that in the blue line, patients with COVID really don't feel all that short of breath. And again, reminds that we don't ventilate and breathe based on how low our oxygen levels are. And so that's why you're almost certainly going to have to walk your COVID patients and ambulate them and assess exactly where their oxygen saturations fall when they're ambulating, simply because they won't tell you they're short of breath. And I've always joked with my folks who need oxygen therapy, the only time that you need oxygen is when you're picking yourself up off the floor because you passed out. And so the idea for us is that if they're not going to be symptomatic to the point where you can assess that they're going to be hypoxic, you absolutely want to put them in a condition where you can determine the level of saturation that they fall to. Again, not just while they're awake sitting in a bed, but get them up and walk them. And more importantly, definitely assess these patients at nighttime to ensure that, again, they don't have nighttime hypoxemia. I also wanted to spend some time talking about what we've learned and which health systems out there in the United States have actually taken a peek at this phenomenon of sending folks home in regards to who's going to be better served to be at home with oxygen versus in the facility. And this information that I have here on the slide comes from JPS, which is a health system in Texas. And so they very clearly were concerned that they were running out of hospital beds and had to come up with a way to get people out of the hospital who were probably not quite ready to make it out of the hospital because of their oxygen requirements. But what they found is that in their early discharge planning, that they were able to send at least most of I wouldn't call them but patients who aren't quite as sick home earlier, and freeing up about 30% of their hospital beds to care for the more sick and gravely ill, so that, again, the resources were placed in the right location. And so what they used as their marker were saturations of 88%, which again would be the Medicare CMS standard. But again, in this current environment, the NIH specifically has stated that 92% should be okay. And I'll get to what CMS has decided to do in regards to reimbursement. But I think the idea is that if you're in case management, you're involved with discharge planning, you want to get out and talk with your DME companies. You want to talk with your local servicers, because I think you're going to want to have a proactive plan about how to get patients who are not quite ready to go home, but also not quite sick enough to stay in a hospital, and more importantly, maybe not grave enough to end up in skilled nursing or acute rehab. So there is a continuum of COVID infection, and I think what the folks in JPS did rather astutely was come up with a plan to have oxygen concentrators available and oxygen tanks available, so that when patients got to the point where they were COVID negative but still likely to need some oxygen therapy, they were able to discharge those patients with good care. But the downside of that, and I think this is why I'm concerned we may not be prepared, which is that just roughly 50 miles or so away from the JPS hospital system that I just described, in McAllen, Texas, they did not have that same ability, mostly because, again, there were limited resources. So what we found is that in having the right discharge plan, unfortunately, we lost the ability to give all of that great discharge plan oxygen concentrators to other hospital systems. So that leads to competition. And so I think that's where my frustration may lay in the next couple of months, is that now is the time to start stocking your DME companies with more concentrators, so that you're prepared for the ensuing what I suspect will be increased need. Because I think, again, what unfortunately they learned in South Texas is that when one hospital system gets it right, it's going to limit the availability of other concentrators for other parts of the state. And that, unfortunately, likely led to more hospitalization or prolonged hospitalization for some. And so I think if at all costs you can get together with your discharge planning, get your local DME companies and start stockpiling concentrators and oxygen tanks, I suspect patients will fare better in the wintertime. So without direction, where do we go? And I think that's, again, with this third wave starting to uptick, we still don't have direction of how to manage this concern. This slide just demonstrates again that even in third world countries, where we expect there to be a limited resource of oxygen, the idea is that many of those folks have probably never been on oxygen before. So that means that you have to spend some time not just writing the prescription appropriately for the patient, but you need to explain how to use those oxygen systems for family, because without adequate information, People are going to go home with tanked oxygen, not know how to use it. They're going to go home with concentrators and not know how to adjust them. But the other thing we've recognized is that some physicians don't write prescriptions really well. So again, I lean on my respiratory therapist a lot in order to, again, not just assess the actual needs of patients, but to ensure that the prescriptions are written appropriately for patients. Because 2 liters on a tanked oxygen delivery is not the same as a setting 2 on an oxygen concentrator. So that key piece of information is often missed by clinicians. And I think that if we're going to send folks home, we're almost certainly going to want to have the ABCs of how to manage oxygen, how to keep people safe, more importantly, not to smoke near it. That's another thing that we've recognized is some patients were smokers who went home with oxygen, didn't need it before COVID, but certainly needed it afterwards, and unfortunately have returned to the facility with burns associated with trying to smoke at the same time they're receiving their tanked oxygen. So danger. So a large degree of information and more importantly, a large degree of education really needs to start now. So there are no examples out there, and I'll be completely honest with you. I had to go all the way outside the United States to find information about how to send patients home safely with oxygen, which is really distressing to say the least, since I suspect our healthcare systems really should be performing better than we have. But this is a paper that comes from India. They've obviously, in a resource-poor part of the world, really needed to do what they can and could to increase the number of people going home, so that, again, with the limited resource of beds, they were able to free up those beds for sicker patients. And so I'll leave this algorithm for you to follow. And I think the idea is that they have frequent assessments, which is you just don't send folks home with oxygen without having them have some means to assess whether they're safe or whether they need some titration of that therapy going forward. So in the setting of this algorithm, about every 48 hours, they would assess these patients to, again, ensure that they weren't desaturating and requiring hospitalization. More importantly, if they did, unfortunately, desaturate to a point that was less than 93%, and then those were patients that were asked to return to the facilities and unfortunately be hospitalized due to their COVID illness. But I think in this planning stage of where we're at currently, I think this gives a good roadmap for many patients, and more importantly for case managers and anybody that's working with discharge planning to at least have some frame of reference in regards to who and how you can get some patients home rather early. Again, I think concentrators are a great way to get folks home early. Tanked oxygen may not be quite as available, and more importantly, a lot harder for many patients to understand how to use, whereas a concentrator may give some simplicity in regards to how to devise and prescribe the devices. So as I said, they didn't send folks home without having some way of triaging. And again, in the setting of not having patients come back to a facility because of COVID or fears of COVID, telehealth was another means for patients to either call in or be called in order to tell us whether they were doing well in this paradigm. So again, asking the questions about how their oxygen saturations were, how their heart rates were faring, were they afebrile or still having some degree of temperature, and then allowing people to tell us whether they were feeling more short of breath. So are the respiratory rates really high, or are they improving to, again, where the patients felt that they were safe to stay at home and not deteriorating to the point where they need to be evaluated in the hospital. So the guidance, as I mentioned before, the whole goal now is to send patients home safely. And I think in this current pandemic, Medicare and Medicaid has waived all the requirements necessary, not just for in-person testing, but also for deciding who gets to go home with supplemental oxygen. So I think if you've got patients who are sitting on the fence between going home or staying within the facility, and oxygen is the issue, but they don't meet those prototypical standards that we would use in patients who prior needed to have saturations less than 88% or some degree of heart failure with arterial blood gas, PaO2 of 59. All that's gone out the window during this pandemic wave, again, mostly due to emergency use authorization. So if you look at the bottom, I've got the local the delivery codes that you would need in order to prescribe on your medical need forms, so that, again, you're able to send patients home. And it just has to be reinforced that you're sending patients home at the time of COVID, and that these are not COPD patients. They're not heart failure patients. They're patients, unfortunately, that have been infected by COVID that are unfortunately not oxygenating where they need to be. The question always comes, how long will we need that therapy? And I think the idea is that every patient will be different, which is another reason why you have to frequently assess whether patients are clinically improving and in no longer need of having the need of a device to keep their oxygen saturations appropriate. But I think collaboration is the key. I think if you can get a case management team together Start talking with medical staff, hospitalists, respiratory therapists, absolutely, because they're going to be the ones that assessing, my guess is, in the hospital and certainly nursing for sure. That's where the third-party vendors will come into play, because I think if you reached out with the appropriate needs, hopefully somebody will catch those needs and assist the hospital systems. So again, you're not trying to figure this out individually for each patient in real time. But I think that discussion really needs to start this week, and more importantly, before we get towards Christmas, because I suspect that this winter is not going to be a very kind winter for some folks, and I think hospital systems are going to bear the brunt of that. And so I think the plan of care really should start at the time patients are admitted, so that, again, if they fall into stage 2B or even stage 3, where they've unfortunately had prolonged hospitalization, you know what that trajectory will look like in regards to getting them home with oxygen, so that, again, you're not trying to do it in real time. You've already made that plan maybe a week or so before the patients are ready to go home. So chronic illness, and I think this is the other sad part that I have to share, which is that, I, being a member of the COPD Foundation on the Research Advisory Board, we don't have anything specifically that we've put together in regards to a document to say this is what our COPD population needs to do. I would remind that any chronic illness increases the chances and susceptibility to the virus, but we have not found that patients with COPD are at graver risk of having a bad outcome compared to others. So I don't presume, and I don't scare my patients, my prior patients, into thinking that they have to fear the worst outcome. But we do tell our folks that absolutely are on oxygen now, that if they have increased symptoms that suggest exacerbation of COPD, if they're measuring their oxygen saturations at home and they, again, fall to less than 92%, that rather than sitting at home and waiting to decide if they're getting sicker, they should really allow a clinician see them so that we can make that determination. Because I think, patients who are silently hypoxic sometimes don't make it to the facilities in time for us to change the trajectory of their illness. So early presentation for patients with COPD is what I would recommend. And again, we don't have anything formally that's been placed into a document to suggest how to get these patients home after they've been admitted. And unfortunately, we have some COPDers who weren't on oxygen therapy who are now going home with oxygen. And that can be a life-changing event. But again, I think the idea that these are patients that are likely to get better, again, for me as a pulmonologist, I would prefer that they go home with oxygen for even a short period of time, and that we counsel that their oxygenation may improve to where they no longer need it like they had done prior to being infected. Again, the Pulmonary Fibrosis Foundation, kind of the same. Now, many of my patients with fibrosis fall off a cliff. They assess their oxygenation rather astutely, rather quickly, multiple times during the day. So they're very keen on when their oxygen levels are dropping and how to adjust their oxygen therapies. So for my folks with pulmonary fibrosis, I've reminded that if they've fallen off a cliff and they've not recovered, rather than sitting at home waiting to decide whether they have a need to be in the hospital, they should let a clinician make that determination. Because again, if they're already on oxygen therapy, they are already tenuous in regards to how well they'll deal with the virus, and higher flows of oxygen may be necessary in order to keep this condition safe. So I think the idea that fibrotic lung diseases may fare a little differently than patients with obstructive lung diseases means I'm a little bit more cautious with my fibrosis folks. I much prefer that they present earlier and not try and manage their conditions at home, simply because they can be quite tenuous in their oxygen requirements. And lastly, pulmonary hypertension. Unfortunately, pulmonary hypertension folks are very symptomatic. And so it's always hard for some of my folks with pulmonary hypertension to really determine what's baseline versus a down day. And so this is where oxygen saturation ranges really play a key role. And I think for my patients who've unfortunately had PH and didn't get COVID, if they're lightheaded more than usual, if they've unfortunately syncopized or had pre-syncopal symptoms, which are greater than usual, even if they've not had fever or changes in shortness of breath, I've asked them to go get evaluated by a COVID test, just to, again, ensure that they're not actively infected, because we do know that clotting is a huge part of the early presentation of this virus. It can be really hard for patients with pulmonary hypertension specifically to tease out, the acute infection versus their chronic illness. And so I've oftentimes tried to ensure that my folks with pulmonary hypertension really pay attention to the ranges of their oxygen saturation and not just the absolutes that they would measure, say, in the morning or in the evening, because I think, again, there are going to be different parts of the day that their saturations bounce all over the place. And so putting together what their saturation ranges look like with any changes in symptoms are generally a good way of determining who needs to be seen in the facilities. So with that, I'll give you my concluding thoughts. I think the disparity of how we're managing COVID-19 really starts with understanding that this is a continuum of illness. Where we originally had thought this was going to be prototypical ARDS, we now recognize that there's a huge component that's a pulmonary vascular source that unfortunately likely can lead towards ARDS due to reperfusion injury to the lung. So the diffusion effects that we see, and we can actually measure that now in some pulmonary function labs, the diffusion lingers. So these are patients not likely to have a robust improvement in their oxygenation after they get better from the virus. So I think the idea that many folks may require oxygen therapy at home for a few weeks, especially after discharge, means that we have to really think about not just telling people that they need oxygen therapy, but educating them about how to use their oxygen, which means we have to not just measure them at rest, we have to measure them while they're ambulating. And more importantly, don't forget to measure them while they're at night sleeping, because again, that is the most dangerous part of the day for any patient that's hypoxic. But any saturation for me that falls to less than 90% should prompt and at least a titration of therapy. And we should educate our folks going home how to titrate their therapy appropriately. Again, this isn't COPD, so we should not have the same level of concern about over titration. But again, I am always cautious about washing in carbon dioxide in some patients that have ventilatory defects that may be associated with the virus. So behaving a little bit like pulmonary hypertension in regards to CO2 may be causing some folks to be more sleepy. So you do have to want to at least have some time to sit and tell folks exactly the downsides of cranking up the oxygen. So again, that they're not trying to overshoot what would keep them safe. So 92 to 96% is generally the recommended goal. And that comes from, again, from the National Institute of Health. And then, get out there and talk with your DME suppliers, get the case managers together. I think if you work in a hospital system where you have an insurer that loves that system, for me, it's United Health. Again, I'm not a United Health client, so I can speak to that. But I think the idea that insurers are going to want to be involved in this early on, because this therapy may not be a short-term therapy. It may last longer than 30 days for some. And so the cost of that care is going to fall onto someone. But we want to make sure that everybody's aware, at least in the setting of where COVID is headed, that this is likely to be a phenomenon that at least goes into the spring, so that if we need to make more supply of, say, oxygen concentrators, then we need to get the manufacturing started now, so that by December and January, we have enough devices for everyone. I'd like to thank you all for your time. Thank you so much. And I will now turn it over for questions.
Hello, Dr. Robinson. Thank you very much for rounding the bend here for the JSM Forum and wrapping up the respiratory track. It's been a great day so far with a lot of amazing topics, and I think ending the day with your topic being so relevant and something that I know there's a lot of interest and a lot of additional need for understanding. So thank you so much for ending our respiratory tract day with your topic and representing on behalf of the JSM and getting us to this point. So if you're okay, we'll go ahead and get right into the Q&A session.
Perfectly fine. Let's do it.
All right. So first question, as we take a look at it, I think it's a hot topic right now about vaccines. And so we had an attendee ask, how do you feel about Pfizer or Moderna mRNA vaccine, and how are these going to be ethically used on children?
That's a very good question. And I think the ethics are really going to lie on what your concerns are up front, meaning are you overly concerned that your child specifically is at risk of having severe disease, or are they healthy enough to fight off the common cold, which it can be like in some patients under the age of 12. I don't know that I have a comparison. I think a virus is unfortunately something that's going to require mitigation in some fashion, and vaccines are going to be the way that we lower the outbreak. And so I think for me, I wouldn't necessarily say one better than the other. We know that you're not going to be able to get one in every part of the country. There are going to be some pockets that have only one type of vaccine, some pockets that may have more than one. There are 200 actually that are being developed internationally. So I think what's available will be safe. I think what's available to children will require us to really have a good discussion about who's at greatest risk of having bad outcomes associated with COVID. But I think the reminder is that kids are generally spreaders of this virus. They don't really fall into the high risk group of patients that we would see that have really severe disease. And so the idea, just like with the flu shot, is how can you minimize spread of the disease? And that's to give it to people that are super spreaders. And I think that's where, for me, with my children specifically, I'm going to have that discussion with my pediatrician about whether I suspect they're going to be super spreaders, as I don't have children at this time that have increased risk.
Hey, thanks, Dr. Robinson. I know that's a very hot topic right now, and appreciate that feedback just to help us all understand from your perspective with how studied you are on the topic. It's definitely helpful to hear that. So when we take a look at some treatment, and as you spoke a lot about the different techniques and equipment being used to treat, we do have a question. Are high PEEP levels the right modality to treat COVID patients?
Well, I think that speaks to whether patients are in ARDS. So in using PEEP, obviously, these are patients that are on a mechanical ventilator. And as you probably are aware of, we try and titrate the therapy based on the severity of illness. And so I don't know that high versus low, again, back to the Gattinoni paper from Italy, really speaks to what we're trying to do and what we're trying to accomplish at the bedside. I think the discussions we've had about high PEEP and low PEEP really go along with my slide referencing the fact that the volume of the lung is not badly affected by the virus. And so generally what we're looking at in the setting of whether high PEEPs are necessary is the compliance of the lung. So if you've got patients on a mechanical ventilator intubated, looking at how stiff that lung is, how low that compliance is, will likely tell you who's going to benefit from PEEP versus those who don't. Again, we recognize clotting as a concern, and as you're probably aware with that question, high PEEPs can affect the right side of the heart and decrease blood flow through the lung and make you hemodynamically unstable and oxygenate worse. And that's something we did recognize, unfortunately, late in some patients with COVID, is that they had vascular concerns. So I think the bedside situation will dictate how much PEEP is necessary. And obviously, the measurements that can be done at the bedside, like a compliance that can be assessed by the ventilator, will tell you whether you've got somebody with recruitable lung that can tolerate higher PEEPs.
Very helpful. And I think another piece, a lot of people are still waiting to see what the long-term effects are of this, and so may not necessarily know the answer to this next question, but we've at least had more data now than we have in the past. Would early intervention with oxygen potentially minimize long-term risk of virus effects?
That is a question we can answer. And as you know, if you're oxygenating appropriately, oxygen doesn't do anything. It's just air that's going into the body and having vasoactive effects within the lung. So if this question is specific to patients with low oxygen saturations, and the discussion we have at our hospital is, can we send folks with 95% saturations home? 95 is not quite normal, but it's also not quite sick. And so in that setting, you're going to want the surrogate data. You're going to want more information to suggest that there are periods where the oxygen saturations are a concern, where early treatment with oxygen might benefit that patient. Again, that's going to be nighttime, so nocturnal saturations. It's certainly going to be getting the patient or the subject up and walking them and seeing if they desaturate, because 95% at rest is not the same as being able to do a 6-minute walk and keep your saturations at 95%. And so I think early treatment is certainly something I would suggest, meaning that if you've got patients that are 93%, low grade temperature, but doing quite well, no end organ damage or suggestions that they've got injury to other organ systems associated with the virus. If you have the means to get those patients home with oxygen therapy and have them use a pulse oximeter and assess their saturations, then just like our colleagues did in India, I would assess them every 48 hours. Have them check their saturations routinely with activity, and to ensure that they know to call you if their saturations fall to less than 90% and what level of oxygen you were providing. So I think that's something that shouldn't be taken off the table for patients as we progress into this third wave.
Very helpful feedback, and I think you had mentioned monitoring after the fact and the importance of that. What is the level of importance, or how do you feel that it's going to need to look in terms of long-term monitoring for those patients who have recovered from COVID-19?
So recovery will look very different for a lot of different folks. I've had family units where the husband was not quite as affected. The wife got critically ill on a ventilator for 3 weeks, and then eventually recovered well enough to actually go home and not to skilled nursing. And so it really speaks to who's going to be able to take care of that patient when they leave. Meaning, is it really going to be home health? Is it going to be physical therapy coming frequently to get patients better? Or is it going to be like the one patient I just described, the husband, who didn't get as badly infected with the virus and could take care of his spouse? And so, I don't know that there's a direct answer because this disease is so heterogeneous in its effect. I think there's going to be grades of how we decide who gets what, intensities of how much intervention that we request of nursing, and more importantly, what sort of services are going to best fit the scenarios and the social setting, that the patients are going to be living within. So how much help are they going to have? And unfortunately, if you're over the age of 65 and widowed, that may not be as great as somebody, say, in their mid-50s, still married with children. So that obviously goes back to the level of insurance carriage that most patients will have, because I think home health for many was a great way to accomplish lots of goals, assessments, making sure patients are doing better, but more importantly, having the nursing necessary, provided, again, some patients may need some therapies. So having nursing to be able to go home would be beneficial also.
Well, and I promise this was not a planted question from me or MSC, but the question is relevant to DMEs and the role that the importance of DMEs moving forward, taking care of the sicker patients related to COVID. I mean, what do you envision that role of the DME company being, and does it become more and more important as we move forward, or just your general thoughts?
DME companies have always been sort of an afterthought. We hadn't really put them at the front of the discussion in regards to not just the capabilities, but, and obviously I'm aware that they're small markets, they're large markets. I'm aware that not every DME company can stock every single device that's available in the respiratory market space. But I am aware that, based on local needs, based on local discussions, DME companies should be part of that early, at least, involvement in deciding what they can afford to stock, because I'm aware DME companies are companies just like any other small company. So who's going to help them to achieve the goal of making sure that the population that they're responsible for and to can be well cared for? And so, for me, DME companies have often, unfortunately, you wait till the day of discharge to call, and then you're stuck with trying to figure out what's left behind on the shelf or when the stock's going to be replenished. I would be a proponent for the day the patient's admitted, that social work reaches out to whoever the insurance carrier is in determining which DME companies are going to be appropriately called, and then start that discussion. Because I think, if you wait 3 weeks to have the discussion and then the patient's ready at, day 21 to go home and nobody's really talked about what that looks like, then that just adds more days to the hospitalization, adds more frustration to the social work. But more importantly, the DME company is blamed, probably rather inappropriately, for not being able to keep up with what's going on in real time. And so I think, in all fairness, DME company should be an early part of the discussion so that, again, a plan can be made for each individual without having to wait till the 24 hours before discharge.
Well, and I know you talked on one of your slides just about the importance of collaboration as a whole and really just everybody coming together. And I think all the different elements of care that you talked about throughout your presentation, that's really a resounding message of we're all in this together, and we need to make sure that we know who our supports are for what and incorporate them at the right time. So Dr. Robinson, it's been incredibly helpful to hear everything that you had to say on this topic, and again, such a timely topic, and really appreciate everything that you did to make this event informational, and especially on a topic that we can all relate to right now, unfortunately, during these tough times. So Dr. Robinson, thank you for wrapping things up for us as we come to a close for the JSM Forum and the Q&A, and just appreciate everything you do to help our patients out in the field and help us figure out how we can collaborate better in the future.
I'm happy to have been a participant and look forward to working with you all again in the future.
Thanks a lot, Dr. Robinson. Thank you all, attendees, for a great day, great topics, speakers, and helping us close out this JSM Forum and make it a great event. So thank you all for your time, and don't forget to fill out your forms to receive your CEU credits. And thanks again for being a part of the JSM Forum.